Hello, everybody. Welcome. Happy Friday. Welcome to our Lunch and Learn. Today's topic is going to be Understanding Psychiatric Advance Directives, and I am going to be one of your facilitators. This is Shireen Carrico from Promise Resource Network and Pure Voice, North Carolina. I am not feeling very well today, so I'm not going to show my video, but you should be able to hear me and see my screen. And my co-facilitator, as usual, is Lynn Legier. Want to say hi?
I'm here. I am here. Welcome, everybody. It's great to have you guys on a Friday. We love that. So welcome.
Thank you, Lynn. And Lynn will keep her eye on the chat. I've also asked Lynn to jump in if there are topics that she's really passionate about or familiar with. And I've asked a couple of other folks, like Amanda Martin, who has a lot of experience in facilitating psychiatric advance directives, to also jump in. But that's an offer to everybody. Please feel free to write questions in the chat, put examples in the chat, offer illustrations. Definitely use the chat as we go along. So welcome, everybody. This is learning together while we're apart, what peer support specialists need to know about psychiatric advance directives. So I wanted to start by talking a little bit about why this topic is important. And I think depending on our perspectives of how we answer this, the answer might be a little bit different. So I want you just to ponder that for a moment. Why is this topic, the topic of psychiatric advance directives, important to you personally? Why would it be important to you as a peer support specialist? And why do you think it could be important to people that are involved in the behavioral health systems? So take a moment, think about that, and please write your answers in the chat. As you're thinking about that, I'm just going to give you an illustration from my experience, and Lynn, you're certainly welcome to do that as well. I became involved in mental health systems at a fairly young age, when I was around 12 or 13. And I was really struggling with emotional well-being, with suicidal thoughts, feelings of anxiety. I was experiencing a significant amount of trauma at home, and all of it manifested in what was ended up being labeled as mental illness throughout my life. And there was a point where I was in the process of being involuntarily committed to a psychiatric hospital when I was around 19 years old. And I was in college, and quite honestly, while I was not well and I was struggling for a long time, the idea of having my power removed and sent to a psychiatric hospital against my will was such a triggering of my trauma reaction that I think I pretty much would have done anything that I could to avoid being hospitalized at that time. And as luck had it, I actually did avoid it. There was a loophole in the system, and I was able to prevent my own involuntary commitment. But I have thought about that experience a lot throughout the years, and what hospitalization, what it represented to me, and why I had such a strong visceral reaction. And part of it was the involuntary piece. As a trauma survivor, I had been subjected to a lot of abuse throughout my childhood that I couldn't consent to, that rendered me powerless. And it resulted in a lot of emotional distress and labels and systems that rendered me powerless. And so the last thing I was willing to do was just be hospitalized. It felt like a re-traumatization to me. And so for me, this idea of having an advance directive, something that you absolutely do have some power over your experience, becomes really critical to me personally. And I want to make sure that people have that option available to them as well. So it's part of the reason why I'm so committed to understanding psychiatric advance.
Shireen, I think we lost you. You got muted. Thank you.
There we go. Yep, thank you. If everybody can mute yourself when you join, that would be really helpful to us. So the moral for me is I have become a very strong advocate of people having rights, people having options, people having information about what their options are, and the ability to self-direct what makes sense for them around their trauma experience, around their healing, around their mental health. And psychiatric advance directives are really a tool that could be helpful to some, and it might not be the right thing for others, but it's a tool that I have felt should have been a part of my experience. And I at least want people to be aware that it is available to them if they need it to be a part of their experience. So,
Thank
Lynn,
you.
I'm
And
looking at the chat.
yeah, I wanted to add into it, one of the things that I'm seeing in some of the chats is, of course, people may get advanced directives, but no one spends the time to really have the conversation with them. And for me, as somebody who was in the hospital all the time, I had knowledge about things that had been helpful, things that weren't helpful, particular experiences I had that left me feeling traumatized. And so just going to that particular hospital was re-traumatizing. And, those conversations weren't allowed. And this was before we really had pads. And what I know from having those conversations with other people is the conversation itself is so valuable to help people start thinking about, what do I know about myself? What information do I have, and that I can actually be an agent of informing others. Even that basic thought can be very new to people and very empowering.
And as we look at the chat, there are different answers. Amanda is saying that it was never personally important to her. It wasn't within her experience until, and I'm paraphrasing Amanda, you started learning about the involuntary commitment process, the hospitalization process, and saw some heartbreaking experiences as somebody who had been incarcerated in jail, not in hospitals. And saw a lot of similarities. I agree with that. I also, too, see a lot of similarities around being committed to a psychiatric hospital as well as being incarcerated. It's interesting, though, to me that in my experience and in hearing from a lot of people that have experienced both, that many people say that there's actually more freedom in jail and prison than there is in hospital settings. Which I think is an argument for why a psychiatric advance directive could be beneficial. Abby said it helps us to be able to advocate for ourselves, express our wants and needs. Absolutely. It's actually the only legal tool that we have, and I'll keep coming back to North Carolina because I am going to talk North Carolina specific, but it is really the only legal tool that we have available to us as people that may end up in hospitals due to emotional distress that to some degree has to be viewed, understood, and to some degree honored. And we'll talk about all the loopholes for that. Catherine said that you went to the AHEC training yesterday. Yeah, BB and I were talking about that this morning. BB Smith and I do a lot of these trainings together. She wasn't able to join us today. She's actually traveling, but she said that a couple of people went yesterday and referred or referenced that they were going to come today. So I'm hoping to maybe either fill in some blanks or do some reinforcement of things that you might have learned yesterday.
Or you guys pipe in, if there's something you learned yesterday that adds to what we're presenting, please share it.
Yeah, and NIBEL in Oregon, I always love NIBEL when you join us from Oregon and we can talk a little bit about different states. We are going to be talking about North Carolina today, but I will show people that live out of state or you have loved ones out of state how to find the requirements in your own state. But you're saying that you have an option on the paperwork when people come in to talk about advance directive, but people don't typically end up doing one. We just hand them a big packet with vague descriptions and that your clinicians can take people to the hospital involuntarily. It's a very similar experience, I would say, in North Carolina. Not a lot of people know about it from the lens of, oh, this is an option to me, and what are the advantages and disadvantages? And on the service provider side, what we find is not a lot of people know how to have conversations about advanced directives, how to support people to make an informed decision, whether it's the right thing for them or not the right thing for them. We find that people get a little bit nervous around this conversation because of the ins and outs and the legalese. And so oftentimes we just hand it to them, say, do you want to do this? People say no, and we move on, right? And then they end up becoming involuntarily hospitalized. So while today is not going to be devoted to sharing with you the details and the ins and outs of actually writing up a psychiatric advance directive for yourself or supporting somebody else, I do want to share with you enough information that you feel comfortable having the conversation, knowing some of the pros and cons and quite honestly, some of the legalese and loopholes, knowing what it looks like, and knowing where to go for additional resources and potentially different training on how to actually write a psychiatric advance directive. We do the trainings at Promise Resource Network. We do a lot with AHAC and the Crisis Navigation Project in North Carolina. But I definitely think it's a good training to have to make yourself knowledgeable so that you can do more than hand somebody that document or that form and say, do you want this or you don't want this, do you? So thank you all for joining in the chat. Yeah, Doug is saying there are high rates of IVNC or IVC. I'm going to share what the rates look like in North Carolina right now. And they are very unnecessary at times without little voice for people. And what they do is provide voice and respect. So let's talk about why. I love this illustration on the right side of your
It's gorgeous.
Computer.
I love it.
It's so beautiful, and it really does, to me, speak volumes. If I'm just going to point out a couple of the things in here of why this becomes so critical. The first is on the top left, if we want to address mental health, right? So we are hearing a lot of people talk about mental health, talk about emotional distress, talk about things such as suicide attempts, domestic violence, all of these life experiences that people may have. But if we want to talk about it, we have to dig deeper than pharmaceuticals, than the pathologizing that goes along with the diagnostic system. We have to dig deeper than diagnosis itself. And if we continue to rely solely on a medical model, we continue to do exactly what Doug said, which is have a lot of involuntary hospitalizations, because then we see emotional distress as something that needs to be contained and needs to be kept safe by locking people up in psychiatric hospitals. When we actually start digging deeper beyond those very basic systems, we start realizing that there are so many root causes of what has been labeled as mental health issues or mental illness. I talked briefly in the beginning about my experience with trauma. I feel very strongly that if the adults around me when I came into the mental health system had understood my behavior as signs of trauma, rather than interpreting them as reinforcement of illness, that my experience could have been very different. I ended up carrying with me 7, 8, 9 mental health diagnoses and not a lot of understanding of the role that trauma plays in things like depression and suicidal thoughts and anxiety and obsession. So that's part of the reason why I love this illustration so much. We have to think about mental health being sort of the outward manifestation of internal distress that can be coming from outside of us. And so things like violence and ableism, poverty, neglect, racism, ageism, mass incarceration, lack of access to healthcare, lack of access to housing, all of these things contribute to what we call or label as mental illness. And if we simply try to label it, manage the symptoms with medications, and send people to the hospital when we are concerned about their safety, we are not getting to the root of the issues that actually could support healing from emotional distress. And so given the fact that oftentimes our go-to place is to involuntarily commit somebody or go to a psychiatric hospital, it leaves people with very little space to talk about these other things that have contributed or actually maybe the cause of their emotional distress. So why this topic? Why do you think this topic as a peer support specialist becomes an important one for us to have? Why do you need to know this as a peer working in behavioral health systems with people?
Doug mentions the unique relationship, which I think is so core to this. You know, it's one thing to have a clinician give you sort of this packet and say, okay, you can do this if you want. It's so different when it's a conversation between two people who have had similar experiences, to be able to talk about, you know, what kind of things would you think are important to you? I know for me, this kind of thing was important. It just levels the field so much.
Yeah, it really does. And Nibel's talking about supporting people to find
Yeah.
their voice. You know, we oftentimes take pride in being advocates, and we should take pride in, because being an advocate is a very significant, comes with a hefty responsibility. But we also, there's nothing more powerful than self-advocacy. So supporting people to find their voice, find their power, discuss their preferences, share what's important to them becomes a critical part of healing, especially for somebody that has experienced powerlessness or people having power over.
Yeah, and when we think about folks that have been in systems for a long time, especially the mental health system, people adopt that helplessness, you know, that learned or taught helplessness, and people actually forget how to have those conversations or dig in within to know what's important. I remember at one point when I was working with folks and I asked somebody what his favorite color was, and he said, well, what's yours? I said, well, mine's yellow. It's purple now, but it was yellow back then. And he said, oh, that's my favorite color too. And I knew in that moment, um, he didn't really know what his favorite color was, because he was so used to just complying and agreeing and doing what people told him to do. And so a lot of these conversations are just giving people permission to start to go back within and ask themselves those questions. What do I want? What do I need? What's important to me?
Yeah, and to Doug's point, I'm gonna pull up some of the data from North Carolina. We use involuntary hospitalization at a rate that is really quite remarkable nationally in our state of North Carolina. It took us a very long time, about 3 months, to find this data, to gather it, and to put it out there, because this information is not readily available in our state. It's not publicly provided information. And so we literally had to seek it out and to gather it and do a lot of adding and understanding of the numbers by hand. And so this gives us a sense of where we're at. In North Carolina in 2018, we're at nearly 110,000 incidences of involuntary psychiatric hospitalization. So that is in 1 year, 110,000. That includes children, it includes adults. We don't know a lot about this data in terms of how many people were involuntarily committed multiple times, how many of these individuals it was a one-time involuntary commitment, because part of the challenge that we have in our state is that level of data isn't necessarily captured and it isn't reported. But when we look at numbers like 110,000 people going to psychiatric hospitals involuntarily, we know that we have a large issue in our state. As we started looking back at the data, we gathered 10 years of data from all 100 counties in North Carolina. And what we learned is this number is a 50% increase from 10 years ago. So we have doubled our involuntary hospitalization rates in our state within 10 years. And then we were curious about the financial cost. In average, 1 day of hospitalization in North Carolina, it's about $2,100. And when we look at the rate that we're hospitalizing people, you're looking at 230,677,198 for 1 day of psychiatric hospitalization at this rate. The average length of stay in North Carolina is actually 4 to 10 days. So if you do the math, we are talking about billions of dollars being spent on involuntary hospitalization. Let me tell you what this does not include. This does not include people that are voluntarily hospitalized. This does not include numbers of people that are what they call boarded in emergency departments. So here's a piece of information that you may or may not know, but it's important for you to know as a peer support specialist. People can stay in the emergency department of a hospital, waiting for a psychiatric bed without a legal process in place around involuntary commitment for days and months. So these are people that are not necessarily reported on. They're not in the attention of the court system, and they are held in psychiatric hospitals. These numbers do not include those folks as well. If we were to look at the rate of hospitalization in North Carolina, you would take 110,000. I can only imagine how many we would be above that when you add on voluntary hospitalization and emergency department boarding, as well as the costs. And we know that the human toll on people, on families, is really significant when people are hospitalized, particularly hospitalized against their will. And so part of the role of peer support specialists that we have taken on with Peer Voice North Carolina is to gather the information to make sure that peer support specialists are aware of this information and to create a space for advocating, because this is not an example of a trauma-informed system, and we are looking to build up trauma-informed alternatives to psychiatric hospitalization. So I want to go back to our foundation as peer support specialists, because everything we talk about today is going to fit into one of your three functions as a peer support specialist. It's either going to be part of your role in providing peer support, whether it's individual peer support or group peer support. This is going to fit in a variety of different places within the scope of your peer support role. Or it's going to fit under change agent. As we just talked about, when we look at the numbers, there's an advocacy space for those of us with lived experience around the data, around understanding why we are hospitalizing people at such a high rate, and on top of it, involuntarily. And when we start talking about IVC law and statute, you're going to see a lot of room for some practice that may not be based on voice and choice. And so we want to understand it from the vantage point of being a change agent. And then always we want to figure out what our role is in supporting people through these processes and through these systems by being with them, but not being an agent of the system. So you heard us talk about this in most of the other lunch and learns that we've done. We work in systems because that's part of where our role is, and we have to be knowledgeable about these systems, but we are not an extension of them. We don't use the system language. We do not coerce people. We don't try to convince people or pressure people. We stay in our role as people with lived experience, which is a very difficult thing to do when we are also embedded in systems. And so all three of these things become relevant for us as peer support specialists. So just a really little bit of history. Psychiatric Advance Directives actually came out of a movement around physical health and end-of-life issues. There was an act in 1990 called the Patient Self-Determination Act, and it established laws that gave permission to patients about their rights in medical settings so that they can be offered information and opportunities around advanced care planning. So think about it in terms of healthcare proxy, think about it in terms of end-of-life decisions, do not resuscitate decisions. This law gave people the right to make end-of-life and medical decisions in advance and use healthcare proxy and have their wishes known if they were to become incapacitated. So it started on the medical side and it grew from there to now include mental health, hospitalization. So advanced care planning started around those issues, but if you look at the principles around advanced care planning on the medical side, similar principles apply in planning for mental health crisis. But it came out of this act in 1990.
Mary Ellen, I'm sorry,
Yep,
Shireen,
please.
and Mary Ellen Copeland took from that movement when she was doing the RAP plan, right? And part of a RAP plan is to plan for, potential future hospitalization and put down your needs. So it wasn't a legal document, but it was that same process of thinking about your wants and needs at a time if you may be hospitalized.
Absolutely. And we're going to I have a slide on talking about sort of where RAP plans and crisis plans end and advanced directives begin, because that is a question we get a lot. Well, I have a RAP plan. Doesn't that satisfy the requirements? And I'm going to say maybe to that. And I'll tell you why I would say maybe to that when we get to that space. But there is definitely a connection between RAP plans, crisis planning, and psychiatric advance directives. So in North Carolina, again, it's going to be different in different states. This is how it reads. If you are a capable adult, we'll talk about capability, we'll talk about capacity, we'll talk about incapacity, and we'll talk about competency, because they are not all the same thing when we talk about psychiatric advance directives. So one of the things you want to do is understand what they mean by capable as opposed to competent. You have to be a capable adult, 18 years or older. So psychiatric advance directives in North Carolina do not apply to people under the age of 18 right now. If you're capable and you are an adult, you have the right to make decisions about your health care, including mental health treatment. I'll tell you, after having facilitated a lot of PAD trainings, a lot of one-on-one relationships with people they're considering a psychiatric advance directive, this one statement, the reaction that we get from people is really quite remarkable. More often than not, people believe that they do not have a right to make decisions about their mental health treatment. They may have heard that they have the right to have a healthcare power of attorney, or they have a right around a DNR or something like that. But when we say to people, you have the right to make decisions about your mental health treatment, people are really surprised that they have rights. And so we want to make sure that people understand their rights as well as understand the limitations of the law. With a psychiatric advance directive, there are legal documents that support your rights. And they are called Advance Instruction for Mental Health Treatment in the state of North Carolina. Other states use other language. To make it easier so I don't have to keep saying Advanced Instruction for Mental Health Treatment, I'm going to call it a PAD, a Psychiatric Advance Directive. It is a legal document. It is written in general statutes and is supported by the Patient Self-Determination Act of 1990. So it is written, it is a law, and it is in statute in the state of North Carolina. Part of the challenge is most people don't realize that it is in statute. They don't realize that there are legal rights, and it is not necessarily understood and honored to the point where the law allows it. And so that is part of the reason why we are doing these trainings. So just generically, psychiatric advance directives allow us to be our own self-advocates. I'm going to say in air quotes, because of some limitations. It is a legal document in the state of North Carolina. Actually, in North Carolina, it's two legal documents that can be combined. It is written by you in advance of a crisis. So very similar as Lynn talked about a wellness recovery action plan, you write a psychiatric advance directive when you are well, not in the middle of a crisis. you actually cannot write a psychiatric advance directive while you are being hospitalized for psychiatric reasons and have it notarized and have it legalized if you are in the middle of an involuntary commitment. And so it is really important as we talk to people about the right to have an advance directive. Sometimes what will happen is people will call us and say, I'm being hospitalized or I'm in the hospital against my will. I want to write up a pad. It is not legal at that point in the state to write a psychiatric advance directive and have it legalized in North Carolina during the middle of an involuntary hospitalization, which is part of the reason why we want to support people to write it advanced. It identifies your preferences, and we'll go into what types of preferences are allowable or recognized under a psychiatric advance directive and what types of preferences are not. It also allows us to identify what works and doesn't work if I were to ever be hospitalized due to mental health issues, and it identifies my level of consent. So those are some very generic, some very basic things that we will dive into. So this is a slide I was telling you about with Wellness Recovery Action Plan. How does a psychiatric advance directive compare to a RAP? Well, they're both done when we are well, and they're both tools to identify our preferences. Where they differ is the level of statute or how legal and binding the tool is. Typically, a RAP plan is not a legal tool. It is a self-help tool. It is a tool to communicate with people that we care about, that care about us, about what our preferences would be if we were to experience a crisis. It's a tool to help us better understand what wellness feels like, what it looks like, and what the signs are when we are starting to feel a bit unwell. It is an excellent planning tool. It is not a legal tool, which means that it doesn't have to be followed in North Carolina. If you were to show up with a RAP plan at a psychiatric hospital, it is not a legal tool. In saying that, I do recommend to people that they have their RAP tool along with their psychiatric advance directive so that there is over communication if they feel comfortable sharing their RAP plan, so that there is over communication around their preferences. I would rather there be over communication for myself than to leave holes in the information and allow people to guess or interpret. But a RAP plan is typically not a legal tool. A psychiatric advance directive is. A psychiatric advance directive primarily focuses on what happens once you are in the hospital. So the only time it gets activated is if you are in a psychiatric setting, in an inpatient setting, and you are incapacitated. And the psychiatric advance directive does not need to go into place if you can speak for yourself, if you can share your own voice or share your own preferences. Although I will tell you, to have it written down and to have other people know what your preferences are and have other people supporting you through that process can be incredibly helpful. But it is typically for medical settings. So when you go to write a psychiatric advance directive for yourself or with somebody else, what you're thinking about is what are my preferences in a hospital setting. You also can add instructions for things outside of the hospital, such as caring for your children or your pets, paying bills, tending for your house, things like that while you are incapacitated or you're in the hospital. I have personally found developing a RAP plan can be great preparation for developing an advance directive because some of the items that you put in your RAP plan can go directly into a psychiatric advance directive. They're just not the same thing. Now, in North Carolina, it's interesting because you actually do not have to have a specific document for it to be legal, although there is a document I'm going to share with you. You can walk in with a RAP plan. The issue is, in what we've heard from several hospitals, is it doesn't look legal, it is not notarized, and they may not treat it as a legal document, which is why you want something that is notarized and more consistent with a legal document. hope that made sense. I didn't confuse.
The one thing too about having a psychiatric advance directive is even if you are able to speak, by virtue of having a quote unquote mental illness, people take away your capability to speak clearly. Even if you're doing that, it's just an assumption that if you're having a mental health crisis, you do not have the capacity to think things through in a capable way. So having that document of something that you did prior to the moment of crisis brings in greater credibility, because sadly, even if you're voicing things, your voice may not be taken seriously.
That's right. And one of the advantages that I find of having a psychiatric advance directive, although it's not fail-proof, but when it's written, when it is notarized, when it is witnessed, and when we have people that love us, or you have, you're connected to a strong advocate, there is something that can be advocated for that is in writing. Typically, sometimes if we're experiencing a mental health crisis, we may not be able to articulate everything that we would have before the crisis. If we are in a hospital setting, it's a different type of setting. If we've gone through a legal process, so having it written down can be very helpful as a communication tool, whether we are incapacitated or not, is really what it is. It's a tool. So it's interesting what's happening around psychiatric advance directives on the legal side and the statute side. There is a very strong push happening right now nationally around having psychiatric advance directives in statutes and in place. There are a lot of reasons for that. And there's a lot of suspicion, I'll be honest with you, from the community of people with lived experience around what's happening at the national level and why such a strong push for PADs. At the state level in North Carolina, a general statute just went into effect not that long ago that had a heavy focus on the use of psychiatric advance directives. And I put this link in here so you can go back and actually look at what the statute says through the General Assembly. And where we live in North Carolina, in Mecklenburg County, the use of psychiatric advance directives has actually made it to our countywide mental health plan that we are looking to have increased awareness of psychiatric advance directives, people that can help facilitate the development of PAD, and a push within our hospital and crisis systems for providers to be trained about what a psychiatric advance directive is and what their requirements are in terms of honoring a psychiatric advance directive. So we're seeing a lot of focus right now being paid on the psychiatric advance directives, probably since about 2018, 2017, I would say. So if you do not live in North Carolina, or you have loved ones that live out of state, I wanted to give you this snapshot. This is actually a national resource center on psychiatric advance directives. It's called NRC PAD. This is their homepage. When you go to this page, you can't really see it on this slide, but at the bottom of this page, you're gonna see it says state by state information. If you were to click on that and type in your state, all of the statutes and documents specific to your state will come up. So it's a very useful resource in terms of getting deeper into what your statute says, how far the legal requirements go, what the limitations are, and if you have specific process or documents that are required, those will come up as well. There is information in here on research and videos and FAQs, as well as some legal issues around psychiatric advance directives. And the link there is at the bottom, nrc-pad.org/. The information I'm going to share with you today around North Carolina, you can find on this site as well. So I think it's really important for us to know the nuances of this because as peer support specialists, we are not advocating for or advocating against the use of a psychiatric advance directive. For us, we are kind of neutral. It's a tool, it's information for people to have that can support people to make an informed decision, but we are not in the position of pushing for it or pushing against it. We do have to have enough information to be able to answer questions or gather the information as we're supporting people to explore whether it's the right thing for them. Here's one of those nuances in North Carolina. What is capacity? And this is really how general it is. It is written in statute that it's a term for the person's ability to make rational decisions based upon relevant facts and considerations. And so a PAD goes into effect in North Carolina if you are deemed to lack capacity, meaning you don't have the ability to make decisions based on this relevant information and facts. And so as a question to all of you, and you can write it in the chat box, when do you think legally a person might lack capacity under this statute? What is an example of where somebody may be deemed to lack capacity that is consistent with what this legalese is basically saying? Okay, Amanda said when some old ass white man says they do. So Amanda, I'm going to read into that what you're saying is if a psychiatrist, a psychologist, I don't know if that's who you're referring to as old ass white dude, but if somebody in an authority position deems that you lack capacity, then maybe perhaps that is when this goes into effect. I'm going to say that is kind of true, without saying the white old ass man type of thing, but there is some parameters in here about assessing for capacity, which is part of the pushback, quite honestly, on the advocacy side for psychiatric advance directives. Some of these determinations are very, very loose. So Alyssa says grandiose. So I'm going to assume that that means that if you have been deemed to be thinking what would clinically be deemed grandiose terms. Lynn says by virtue of having a psychiatric illness, a biological brain disease, you may be deemed to lack capacity. Somebody else says suicide, when someone has difficulty answering questions about shared reality, like what day it is, where they are, possibly euphoria. Alyssa says it is subjective. Lori Coker agrees with that. Okay, so we're all over the place in our answer to this. So all of you are kind of right in one way or another. There are some clear circumstances that you would be deemed incapable of sharing your preferences orally. If you come in and you literally cannot speak, you cannot answer questions, and there are a lot of reasons why we may experience that in the middle of a mental health crisis or emotional distress. If you literally cannot speak for yourself, you would be determined to lack capacity. If you're speaking, but you're not answering questions consistent with what they determine the relevancy of the question is, meaning that they're asking you preferences and you're talking about McDonald's, they may deem you incapacitated or incapable of making a decision. What is it? So it is the opinion, the evaluation of a physician or a psychologist to determine whether you lack capacity. Now, here's a couple things around that. Number one, it has to be documented in your chart that you lack capacity, and legally, it has to be documented some substantiation of why you lack capacity. Number two, capacity and competency are not the same thing. So competency is determined through a legal process. So you actually go in front of a judge, somebody petitions, says that you are not competent because you don't understand proceedings or you cannot speak for yourself. That is a legal process. Capacity is a psychological process, and it is more done through evaluation. What does it mean to say that you lack capacity? Does it mean that you can't make decisions for yourself? No, it means that if you have a PAD, your Psychiatric Advance Directive, should be then used as your voice. That is what it says in law. Here's where the frustration comes from. If people have not been trained around PADs, you don't have the ability to advocate for yourself, and you don't have people around you that are advocating for you, you can pretty much drive a Mack truck through this capacity definition. And that becomes part of the frustration. As we talked about in the beginning, as a peer support specialist, part of our role is change agent. And when we see legal issues, statutes, and things coming into play that can affect our rights, our freedom, our voice, and our choice, these may be places where we decide to be strong advocates. This may be a place to be a strong advocate. But right now, lacking capacity means that an evaluation has been done by a physician or a psychologist saying that you cannot understand or have the capacity to communicate your treatment decisions. In that case, a Psychiatric Advance Directive might go into effect. So here's another difference between competency and capacity. Capacity is temporary. So it is basically saying right now, in this moment, you can't answer these questions or advocate on your own behalf. You can't share preferences, and it needs to be documented in your record that you lack capacity. It also needs to be documented when you regain capacity. So it is a temporary state. Temporary does not mean while you're hospitalized. Temporary means during this evaluation, you lack the ability to share your preferences, therefore your Psychiatric Advance Directive goes into effect. It is not in effect for the duration of your hospitalization by law, by statute. And as I said, capacity is not competency. So keep in mind a few things. Because you're going to use a Psychiatric Advance Directive in a medical setting, your preferences are going to be used to communicate with your medical teams. So you want to write it and think about it in those terms. It is a communication tool. It is a legal communication tool, but it is a communication tool. It allows you to let people what you know, what works and what doesn't work for you if you can't speak for yourself. But it is also a communication tool for peer support specialists to advocate on your behalf, for a healthcare power of attorney or proxy to advocate on your behalf, or even if you can speak, you do have capacity and you want to use your tool to communicate your preferences, you can do that as well. I definitely recommend that for everything that you are putting a preference down, you give reasons for why you're including it. So if you're putting a statement down that I will never accept medication A, B, and C, so don't even give it to me, write down why. I've tried it before, it didn't work for me, I have a medical reaction to it, I'm allergic to it, it has given me bad side effects. Whatever your reasons for, you cannot over communicate, in my opinion, in a PAD. But if it's not written down, then there could be some interpretation there that I personally would not want to leave it out there. There are, in North Carolina, 2 parts to a Psychiatric Advance Directive. You can have 1, 2, or both of them together. That is your decision, and we're going to go over what the 2 parts are. The first one is in General Statute, and I gave you a link to the General Statute below. It's General Statute 122C-77. This is called an Advanced Instruction for Mental Health Treatment. It allows you to consent to treatment advance, what treatments you would consent to, what treatments you would not consent to, state your preferences for treatment, and the preferences include your medications and the facilities that you prefer if you have to be hospitalized. There is again, some nuances to that, and there is a lot of open space for interpretation. And so I'm just going to give you the pros and the cons, the good and the ugly, so that you can decide for yourself and you can pass that along to other people that may be considering a psychiatric advance directive. So that is one document. The other document is a healthcare power of attorney. That's in General Statute 32A-25. The statute is also there linked below. And that allows you to basically select a proxy. The proxy goes into effect if you cannot communicate, if you are incapacitated. So this person does not replace your decision making. It's not like a guardian that they make all of your healthcare decisions for you. They come into play to interpret or communicate your preferences if you are incapacitated. You can limit their rights, or you can give them a lot of rights. The documentation of the rights that you are giving them or limiting them is in a document called the Healthcare Power of Attorney document. The person or people you identify are called your healthcare agents. They should not be putting their own opinion or making decisions on your behalf that are incompatible with the decisions you would have made. Similar to an end of life, a do not resuscitate. I have a DNR, but I have a healthcare power of attorney. My DNR's responsibility, or I'm sorry, my healthcare power of attorney's responsibility is to make sure that my DNR is being activated under conditions in which I am incapacitated and I can't speak for myself. It is not the healthcare powers of attorney's role to negate my DNR. It works similarly on the mental health side. And again, these tools can be used together or they can be used independent. You don't need both. You can only have, you can decide that you want an advanced instruction without a healthcare power of attorney, or you want a power of attorney without an instruction. Lynn, how's our chat looking? Is there anything we need to address in the chat at this point?
I'm sorry, I was speaking without my mic on. No, some of us have just been chatting about how easy it is to loophole us out of the process around capacity, calling us non-compliant or not having insight, insomnia, all those things. So we've just been chatting about that together.
Okay, and I do see that Lori asked if I had clarified yet the difference between an advanced instruction and an advanced directive. I have not gotten to that point, but when I do, Lori, please feel free to jump in and share your experience and your knowledge, okay? You can either do it by chat or you can unmute yourself. So you're right, it's called an advanced instruction, because it is not an advanced directive. Here we go, Lori. An advanced instruction means that you can share your preferences. It does not mean that you can direct your care, meaning you cannot, through an advanced instruction, have complete decision-making over what happens if you are incapacitated. It usually permits you to do a few things. Number one, to plan for, consent, or refuse. I'm going to say refuse in air quotes because there's some nuances to that. Hospital admission, medications or certain medications, electroconvulsive treatments, other treatments. Now, Lori, this might be a good place for you to jump in. Can you unmute yourself?
Yes, I just feel like it's important that we understand that what we are calling advanced directives are, that kind of implies a level of power that comes with these documents that is not really there. And so it can be really important to do advanced directives simply because it helps us with self-advocacy, but we need to understand that it makes it a little easier for our information to be used simply as information and therefore dismissed. And so while I think it's a great idea to do advanced directives, unfortunately, the way our statutes are written in North Carolina, they don't really give us the level of power as a true advanced directive. Like, it's not equivalent to physical health care advanced directives.
Right. It is much more used as knowing, communicating preferences as it is being able to make the decisions about our own care when we are incapacitated. And there are a lot of reasons why. Part of it is the statute and the way the statute is written. Part of it is the lack of reinforcement in the systems for the use of psychiatric advance directives or advanced instruction the way that they were intended to be done. Here's an example. So we worked a lot with hospitals here in Mecklenburg County around advanced instruction. And one of the things that we were being told is not enough people are coming to the hospital with a pad for us to change our policies and our processes around to be able to really honor the psychiatric advanced instruction. So there is a supply and a demand issue that we have in North Carolina. That means that we are not demanding psychiatric advance directives, and crisis and hospital systems aren't looking for them.
And the problem,
yeah, go ahead.
I was just gonna say, it makes it that much easier. It's kind of a cop-out on the hospital end when we supposedly have statutes in place that are protecting this process, but it's that treatment culture issue. And so it's kind of one of those chicken and egg things. If by our demand level being raised, we can help usher in kind of a different thought culture, then we may have different results. But I think part of my concern is that because they're called advanced directives, we're thinking they do things that we really don't. And some of the people who have touted them, who are not people who themselves have lived experience, often they use this as, they use it because on paper it looks like North Carolina is doing things that are trying to empower people's voices, but it's really questionable to what degree it does that. And so there potentially could be an opportunity that we all need to take as advocates to get the language strengthened that really protects our rights in the situation.
Absolutely. Yeah, I mean, and this is part of, Lori, why it's important to know this information and understand the limitations of it, understand where there is, I've been using the term loopholes, or it is not clear, it's open for interpretation, and understand where our advocacy comes in as people with lived experience, and also know enough to be able to have conversations with others so they can make a decision themselves around having a psychiatric advance directive. I can tell you, we have utilized PADS as an advocating tool within hospitals in Mecklenburg County. So if somebody is, for example, being put on a medication or being required to consent to a treatment that we know that they do not want or that has had a negative impact, and they have a psychiatric advance directive, we are able to use that within the hospital system to advocate and push for a different line of treatment. But it is going to take a universal change in the statute, a universal use of psychiatric advance directives on both ends for us to start making some really significant changes for these documents to truly be powerful. So this is the front page. It's called an advanced instruction for mental health treatment. This is the document in North Carolina, and you are going to see this link to the Advanced Health Care Directive Registry maintained by the North Carolina Secretary of the State. What this is a repository that you can upload your actually you can't upload, it's not tech savvy, you have to mail it to the Secretary of the State, and they would upload it into the registry so that if you find yourself being hospitalized and you need access to your advance directive, you could go to the registry and access your advance directive. There are a lot of glitches to this system. It is not fail-proof in any way, shape, or form. First, it costs money. I believe is it $5 or $10 now, Amanda? I can't remember. It's either 5 or 10.
It's $10 now.
$10 now. When we started, it was $5. You have to mail it, so you can't upload it. You have to get a password and a login information and keep that with you so that if you were to be hospitalized, you can access it. It is not a perfect system, and in North Carolina, it's the only system we have that is a single place to be able to have your psychiatric advance directive stored. For this reason, one of the things that we recommend very, 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 very highly is whichever hospitals you have a tendency to either be sent to or go to, bring your advance directive to the medical department, or the medical records department, I should say, and have them upload it into your medical record and have them flag it so that if you were to ever be hospitalized, you have it in your medical record. That's imperfect too, because I have to tell you, if you were to revoke or update your advanced instruction, you have to go back, you have to have them remove the one that they have in their system, and you have to give them the one, your updated version, or they will use the one that they have uploaded in their system. There is no way to keep them updated and live in real time. So if you update it or you change it in any way, every place that has your advanced directive or your advanced instruction, you have to go and replace it as well. Okay, before we end, I will pull up the entire advanced instruction so you can see what it looks like. So making an advanced instruction in North Carolina, as we said, it's an adult, 18 years of older, that has to be determined to be of sound mind, meaning that you can make decisions. Here are some of the nuances in our state that aren't necessarily true in other states. So for you folks that are in Oregon, this is not necessarily going to be the case in your situation. In North Carolina, it has to be signed as witnessed by two people to say that you are of sound mind. Those two people cannot be a relative. They cannot be related or connected to a mental health provider or staff. A peer support specialist cannot be a witness to your psychiatric advance directive. The front office person in the mental health, if you're receiving outpatient services, cannot be a witness. Other staff of the agency cannot be a witness. And it cannot be a staff of the healthcare facility in which you are a patient of. This one caveat can be a significant deterrent for people. And it is for this reason that we make sure that we have available witnesses and a notary when somebody wants a psychiatric advance directive. We do that as peer support specialists because this can be a difficult thing to organize or arrange. The witnesses actually have to see you sign it and attest, and the notary has to see the witnesses sign it and attest. It must be notarized in the state of North Carolina, and it has to be presented to treatment providers in order for it to be recognized. So that's why you have to bring it to a hospital. You have to make sure you have a copy of it in your charts with your mental health service providers, all of those sort of things. It is very clunky, to say the least. And unfortunately, oftentimes creates a lot of barriers for people. I do understand why we would not want to have a mental health provider being a witness. I think there is fear of coercion. There is fear of somebody else putting their preferences in there for you, or trying to force you to put your preferences in when they have some sort of biased advantage for what is written. And I think that is what this is trying to avoid. However, it does make it very difficult in actuality to have a psychiatric advance directive or advanced instruction be activated in North Carolina. Yeah, so Amy said you don't have to share the document or its context. The witness and notary only sign the last page to make sure it is a legal document. Absolutely. Yeah, and Juanita is saying when her father got sick, that you had to ask a complete stranger to assist with the document. So what are some examples of a witness who can account for your mental health status? Well, so here's part of the rub, right? When they say an adult sound of mind, the reality is a witness is not going to be able to attest to your sound of mind, but that's what they're being asked to do. They're basically, what it comes down to is this person signing their advanced instruction and they seem able to know what's going on? That's basically what you're accounting for. And oftentimes we have to utilize people through other advocacy organizations or people that are independent, businesses next door, strangers, to come in and serve as a witness for somebody that doesn't know the individual, but can clearly see that the person is consenting of their own accord. Amanda has pulled people off the street. I've had to do the same thing. Again, it can be very cumbersome to do this. You also can add additional instructions. So instructions for your children, your pets, you need to make arrangements, have personal matters tended to. I actually would recommend you putting that in there. Again, in an advanced instruction, to me, you can't overly communicate, particularly if there are people that support you, that can advocate on your behalf, outside and inside the system, to make sure that they are very clear about what you want and what you need. Okay, what are the exceptions for your PAD to be followed? Here are some of the nuances. By statute in North Carolina, treatment providers are required to follow your PAD with a few exceptions. And here are the exceptions. This is actually part of where the advocacy needs to come in to play, is shifting this language right here. So, number one, if you ask for something that is not standard care, what does that mean? That means that you want to have a cheeseburger to treat your anxiety. That is not considered standard medical care. If you put something like that in your advanced instruction and it is inconsistent with what standard care would be for whatever it is that you're experiencing, then it can be disregarded. Number two, if you ask for something that is not available or not feasible. So if I put a preference in for a hospital and I say I don't ever want to go to that hospital, but the hospital that I prefer does not have a bed, they do not have to follow, number one, your preference to go to that hospital because there's no bed available. And number two, they do not need to follow your denial of going to the other hospital because it is based on what is available or feasible. If you say, I want to go to this high-end private hospital in Utah, they do not have to follow that. Number three, if it is an emergency, what does that mean? That means that if you cannot speak for yourself, you are in the middle of a psychiatric emergency and decisions have got to be made in the moment to save your life, they are not going to stop and look at your advanced instruction first.
But couldn't they, these exceptions are just a little bit outrageous.
Yep.
If it's an emergency, it can also be a mental health emergency. So the very thing that allows your PAD to go into effect then also makes this exception relevant.
Correct.
They couldn't put it into an effect unless you were in a psychiatric emergency, unable to communicate for yourself. So by virtue of that very emergency, they can invalidate it.
Correct. And they can invalidate it, number four, if you're involuntarily committed. So to answer your question, Alyssa, Yes. If you're involuntarily committed, your pad does not have to be honored.
And this shows one, I think, just for a general community advocacy stance. This gives us great insight of why sometimes going into legislation to get our needs met is not the best way to go.
Well, and this gets to what Lori, you were saying, right? It's fine to have this in place and in statute and to inform people and educate them about their right to have a pad. But there are so many exceptions to how it legally can be honored or used as an advance directive that some people are just like, what's the point? To me, let me tell you my point in doing it. I still did it, and I'll tell you why. It is because if any of you out there that love me, and you know how I feel about coerciveness and forced treatment, if I ever end up in that situation, I want you to take my advance directive and what I would and would not consent to, and I want you to advocate the hell out of it for me. I really do. And it could potentially, and this is my advocacy, this is Shireen is the advocacy side. If they were not to follow my preferences and give me a medication, for example, steroids, I have such a contraindication to steroids. Within 24 hours of taking an injectable steroid, I experienced suicidal ideation, suicidal thoughts. Shortly after that, I experienced psychosis. I have such a bad reaction to injectable steroids. And if I have that down in my Psychiatric Advance Directive and they give it to me anyway and something happens, I want one of you, many friends and colleagues and peers of mine, to take that and do something with it, please.
I agree. I think that's where these have the greatest teeth,
Yes.
is when we start to have some litigation around it and say, listen, you were told it was right there and you just chose to ignore it, and so now you're liable. That's where I think we'll start to see these get some teeth.
Yeah. And Amanda, I'm glad you said this, because there are pockets that we have found that absolutely do honor the advanced directive or advanced instruction. Mobile crisis in our community, we have a great relationship with them and they honor advanced instruction. Our CIT officers, because we have a relationship with them as well, they honor them. And sometimes with some of our jails, depending on which one, they will recognize it, although they don't need to in a jail situation. So there are while the statutes are really loose and there are a lot of exceptions, personally, I believe that when we start showing up and advocating, if for some reason they are not being honored and something happens, we have a way in to push on the statute and on the legal side. Literally, I was told by hospitals, until we get sued, we are not going to change our policy. Okay, I hate that it would come to that. We don't want any of that, right? And I know a lot of treatment people, psychiatrists and psychologists, that are actually very happy when they have a Psychiatric Advance Directive in their hand, because they don't have to interpret what the person wants. That's really what is intended to do. But there are others that don't know what it is or don't know how to utilize it, or quite honestly are afraid of repercussions, afraid of risk, afraid of liability. We have a lot of systems work to do around psychiatric advanced instructions and advanced directives.
I think that's the other wing of this, is really doing far more training and introduction of this to the provider field, so that they're aware of how not following this could set up a liability issue, because sadly that is what they take action on the most. And for those ones who really are there wanting to be the most helpful to people, they will also take it from that spirit.
Yeah. And we've experienced both. in doing psychiatric advance directives with people. We've experienced both. We've experienced people who absolutely follow it and they're relieved to have it. And we have experienced situations where we've had to support the person to advocate or even get involved in legal means to make sure that their advance instruction was honored.
And Amanda's just putting in here, of course, this tragic situation that happens with people in jails who then have mental health symptoms, and they get transferred, but often before they get transferred, they've been terribly mistreated within the jail setting first, you know, and we just have people jumping system to system, and anything like a pad gets just kind of dropped out in that process.
It's lost. So here's another option. And this can be in lieu of, or this can be together. In addition to the advanced instruction for mental health treatment, there is also a form for healthcare power of attorney. This means if you have somebody that you trust, and I say trust in capital, bold, trust, that you can appoint to make the decisions for your treatment. If you are incapable, you can do that legally. You can actually have more than one person designated as your healthcare agent. And their role, though, is not to make their decision, the decision they want to make for you. Their role is to make sure that your decisions that you would have made, if you could vocally make them, that they are being honored and followed through with. You can use them together, you can use them separately, but they are two different forms in North Carolina, and this is the link to the form in the state of North Carolina. When you go to this form, this is what the front part of this looks like. You're gonna see a whole bunch of examples of where you're giving authority or you're limiting authority of a healthcare power of attorney. There is a section in there specifically for mental health. And the section is what type of authority are you limiting or you consenting to for your healthcare power of attorney around mental health treatment. That is a part that you could fill out. You can certainly fill out all of it, but you minimally want to fill out that mental health section if you're specifically giving somebody healthcare power of attorney for mental health. And again, if we have time, I'll pull it up so that you can see what the form looks like. If you choose a healthcare agent, number one, make sure they're willing to serve in the role and they understand what the role is. Number two, they know your preferences. They know your advanced instruction back and forth. Number three, they are willing to be your voice if you cannot be your own voice. And number four, it is someone that you absolutely trust. It can be a good idea to have more than one if you have more than one people that fits those criteria. So if the first person listed is not available, they would go to the second. And there is a space on the document to write that in. How to activate it? Well, it's only activated if you're deemed to be incapable. So if you show up at a psychiatric hospital and you're able to advocate for yourself, you are not deemed to be incapable. If you're deemed incapable, as I said before, it has to be documented in your medical record. And once it's lifted, it needs to be documented and substantiated in your medical record. At that point, the PAD is in effect, as is the healthcare agent, if you have identified a healthcare agent. And then legally, the treating physician and others are obligated, I'm going to say in air quotes, to follow the guidance in your advanced instruction and honor your wishes. This is why it's important to have it documented, and this is why it's important to have other people that know you and love you that are willing to be your voice if you cannot be your own voice. So you will see a few different things on the advanced instruction, and you will see a few different things on the healthcare power of attorney. Specifically, they will ask you about medications that you want or you do not want if you show up in a hospital or crisis situation. They're going to ask you specifically about the hospital you agree to be admitted to and hospitals you would not agree to be admitted to, and how you want to be treated while you are in the hospital. Things like, are you more comfortable in quiet settings or do you prefer to be around other people? And you can choose the people that can come and make decisions for you, that can visit you. You can put as much in there as you want. It doesn't mean it's all going to be honored, but I would say at least make sure it's documented and it's in there. And then, as I said, there are the limitations of PADS that you want to know and you want to be able to share with people. One of the things I'm curious, and we're just not far enough along in this process, is if somebody has an advanced instruction, will it positively affect the use of involuntary commitment? So for example, would there be more of a likelihood of you being able to be at a hospital voluntarily if you had an advance directive in place than just showing up without one? It's a good research project. I would be interested to know if we could push something like that to start avoiding involuntary hospitalization. And Alyssa said, and AOT, assisted outpatient treatment as well. If we use advanced instruction the way that it's intended, will it avoid the use of forced treatment and coerced treatment? I don't know. I don't have an answer to that. I have some anecdotal, but boy, it would be an interesting thing to review, wouldn't it?
Well, and sadly, the other piece that's in here is insurance and the role that insurance plays in basically requiring it to be involuntary to pay. And so that, you know, that's another factor that may, you know, not, may make the role of the PADS not really very valuable because it's really the insurance company that's dictating the kind of admissions.
Right. So when you're communicating with people so that they're making decisions about advanced instruction, that's the reason why I gave you these 2 slides in a nutshell, so you can share this information with people so that they can take it under consideration as they're making decisions about what they want to do around advanced instruction. So this is just a visual. So I have a pad. Now what can I do with it? Well, you obviously want to share it with whomever is involved in your treatment, so they know what your preferences are, so that you have it in your records in case it's needed. You want to go to any hospital that you are likely to show up at and make sure that it's in your record there and it's flagged. You want to give copies to people that support and love you, so that they know exactly what you would want if something were to happen, as well as if you have assigned healthcare agents, make sure they have copies. This is a tough one. Take a copy with you if you're in crisis. I mean, you know, okay, it sounds really good, but can I? Well, you might not be able to. And you can store it with the Secretary of the State on their website, as I said before. This is what the state, North Carolina Secretary of the State website looks like. And this is the page on advanced healthcare directives, and it gives you instruction on how to make sure that it is registered with the state. And these are just some pocket guides. So if you cannot carry an advanced instruction with you, but you want to alert people that you have an advanced instruction, you can literally print this page off, and it's meant as a small trifold to fit in a wallet or a purse. People are welcome to carry this with them as well. So our role as a peer support specialist in this, and I understand we are actually, we're at 127. How did that happen? All this fun stuff, and we're at 127.
Time flies when we're having fun.
I guess it does. So I do want to just do a couple of things around this. Understand that it is not our role to discourage or to encourage the use of an advanced instruction. It is our role as a peer support specialist to make sure that people have the information, that they can look into it with support or without support, and they can make their own decisions without us providing advice either way. We are neutral in it. The only stake that we have in this is that people are able to know that this is an option for them, that they have a legal right to have an advanced instruction, that we are there to support them if they do, that there are some loopholes around it. It is imperfect in a lot of ways, and this is what it does for you, and these are some of the things that you need to take into consideration with the exceptions. That is our role as peer support specialists. We do not give advice. We support people. We don't discourage. We don't try to push somebody into a particular outcome. So it's really important to know what our role is in all of that. And I have some examples. This is actually comes from our values of where consistency with the code of ethics for peer support specialists and supporting somebody around advanced instructions and to make decisions around activating their right or not activating their right to have an advanced instruction comes into play. And then I put information in here on how do you start that conversation? What are the types of questions that you might ask somebody in curiosity so that they can come to a conclusion about whether they think an advanced instruction would be helpful to them or not? And if they do, the types of things that they might want to have in an advanced instruction. And then I use, Lynn, your slides on peer support of how we utilize the peer role to go through this process and what is our role in this. Obviously sharing our own experience of having a PAD or feeling powerless in systems or why we decided to or not to do this ourselves, sharing tools that we have used, what our experience is in the process, is the expert by experience, supporting people to weigh out and balance their options, pro and cons, and research it. Make sure that they are prepared to have the conversations, and if they want a PAD, supporting them to know how to do it, complete it with them. I would recommend peer support specialists become trained in how to write a PAD and all the nuances that go along with writing a psychiatric advance directive, just so that we are not inadvertently doing something that is not consistent with the person's wishes or is incompatible with what the statutes say. So at the end of all of this, and again, you will get these slides, we will post it, you're gonna see a slide on toolkits. So there is an actual toolkit that you can use in working with people, which is the first one on here. There's a toolkit for families and there's a toolkit for clinicians, specifically around PADs. This is an example of one of the ways that we have done this in Mecklenburg County. Every 6 weeks, we had these PAD events where we would have a lawyer present, we would have peer support specialists present, facilitators present, notaries and witnesses. Anybody could just walk in, learn about a PAD, and ask questions and sit down with the facilitator and make their own decision about whether they wanted it or they didn't want it. And then we would support them through the whole process, including getting it registered with the state if they wanted to get it registered. As a peer support specialist, this might be something you offer to your community or you offer to people in your own organization. It helps to remove some of the barriers around the notary, the witnesses, the information. We always had a lawyer present because we wanted to make sure that people had access to free legal interpretation and free legal advice. And we used to do these every 6 weeks. And then I've left you with a slide of some resources around psychiatric advance directives for you to be able to go back and look at. This is my contact information if you have any specific questions. If after that, when we get to a place where we can actually start doing trainings together, you can ask, can you do a training at my organization to teach me how to write up a PAD? Or can we do it virtually? I would love to have conversations with you about it if you're interested in going in that direction. Go to the links, check out the documents, become familiar with them, do a lot of reading, decide what it means for you personally, and know enough information to be able to have good intentional conversations with others so that they can make informed decisions about whether an advanced instruction is right for them. All right, everybody. Happy Friday. Have a great weekend, and we will see you next Friday.
Thank
Thanks,
you,
everyone.
Sherry.
Oh, you're welcome. Thank you, Lynn.
Take care of yourself, darling.
Thank you. You're welcome. Thanks, everybody.
Bye, guys.
Bye. Stay well, stay safe.